1 second, guys. Once I get a confirmation that I am live. Okay, fine. See here. Basically, let me start with the first question here. The first question says that which of the following is not a give emphasis to this, not a candidate gene that is implicated in the causation of non-syndromic cleft lip, cleft palate. So here there are two things. One is non-syndromic. So we know that cleft lip, cleft palate are usually associated with certain syndromes, and there are certain non-syndromic. Non-syndromic means the patient doesn't have any underlying syndrome. Patient will have just cleft lip, cleft palate. However, we know that cleft lip, cleft palate is also a component of many syndromes. So among four options, four genes, which is not a candidate gene that is implicated in the causation of non-syndromic. That means one gene is associated with syndrome. The other genes, the other options, three options here are basically associated with non-syndromic. The options are interferon regulatory factor 6, TGF alpha, MSX1, TGF beta 3. So actually these are the four options. Out of this, if you see, interferon regulatory factor 6 is the correct answer. According to this, if you see, I'll go back to this question later. Let us discuss little things. We know that cleft lip, cleft palate is basically associated with certain syndromes and non-syndromic cases. Syndromes are there, will be there, and non-syndromic will be there. Syndrome, if you see, the most common syndrome that is associated with the cleft lip, cleft palate, this is a very important single learner MCQ. Which is the most common syndrome that is associated with is Van der Waals syndrome. Van der Waals syndrome is a syndrome that is associated with the cleft lip, cleft palate. Please remember this. And Van der Waals syndrome occurs due to the mutation of basically which gene? Interferon regulatory factor 6. So already we have got the correct answer here. Correct answer is IRF6. Interferon regulatory factor 6 is the correct answer. So we will go to the question later. So now what are the other syndromes and genes? Now what are we seeing? We are seeing the syndromes associated with the cleft lip, cleft palate and the associated gene. Pierre-Robin sequence is also associated with cleft palate. What is the gene that is mutated here? SOX9, SOX9. Velocardiofacial syndrome is there, that is associated not exactly with a gene but some chromosomal deletion. And there is also one important syndrome called as CLPED. What is CLPED? Is cleft lip, cleft palate ectodermal dysplasia syndrome. Cleft lip, cleft palate ectodermal dysplasia syndrome. Here, this is associated with the poliovirus receptor like 1 gene. So what are we seeing? We have seen here, we have seen the syndromes and we have seen the genes. So with this, we can come to a conclusion that interferon regulatory factor 6 is associated with Van der Waals syndrome. Now, what are the non-syndromic cleft lip? That means certain gene mutation causes cleft lip, cleft palate. They are not associated with any syndromes. Like, TGF alpha, TGF beta 3, MSX1, So what are these? These are non-syndromic cleft lip, cleft palate. So cleft lip, cleft palate, which are non-syndromic, and what are the genes that are mutated here? TGF alpha, TGF beta 3, MSX1. Okay, 5,10 methylene tetrahydrofolate reductase. RAR. RAR is retinoic acid receptors, and proto-oncogene BCL3. Proto-oncogene BCL3. So these are the certain non-syndromic. That means that if any of these genes are mutated, that will lead to non-syndromic cleft lip, cleft palate. Non-syndromic cleft lip, cleft palate. So let us go to the question now back. Now what the question says that which of the following is not a candidate gene that is implicated in causation of non-syndromic? That means TGF alpha, yes. MSX1, yes. TGF beta 3, yes. All three are non-syndromic. Only interferon regulatory factor 6 is associated with a syndrome. What is the syndrome? Van der Waals syndrome. Van der Waals syndrome. Actually, what do you see in Van der Waals syndrome? In Van der Waals syndrome, we usually see lip pits. Usually we see lip pits. Lower lip pits will be seen. That is a common finding that you see in case of Van der Waals syndrome. So Van der Waals syndrome is not only associated with cleft lip pits, it is also associated with the cleft lip and cleft palate. Okay, let us move on to the next question here. The next question says that the teeth showing numerous pinpoint pits. You can see here, this is an image, clinical image. So many pinpoint pits are there across the surface of the teeth, and the enamel between the pits is of normal thickness. So there are so many pits here like this, and whatever is the enamel that is there in between these pits, it is of normal thickness, normal hardness and coloration. What is the most common clinical finding? That what is this? What is the diagnosis? The diagnosis is basically hypoplastic amelogenesis imperfecta. So we know that amelogenesis imperfecta basically is hereditary type of, basically the hereditary type of enamel hypoplasia. So enamel hypoplasia can be because of hereditary or can be because of environmental causes. Hereditary enamel hypoplasia is also known as amelogenesis imperfecta. This amelogenesis imperfecta is of mainly 4 types: hypoplastic, hypomaturation, hypocalcification, hypocalcification with taurodontism. This is known as Wittkop's classification. Wittkop is a scientist who has classified the amelogenesis imperfecta. He has classified the amelogenesis imperfecta as 4 types: hypoplastic amelogenesis imperfecta, hypomaturation, hypocalcification, hypocalcification with taurodontism. So these are the basically 4 types. Now this is typically a hypoplastic amelogenesis imperfecta. So basically, if you see here, the hypoplastic amelogenesis imperfecta shows basic defect in the elaboration of the organic matrix. So basic problem with the hypoplastic amelogenesis imperfecta. See, basically enamel formation requires 2 things. Step 1, organic matrix is produced. What is step 2? Step 2 is mineralization. Okay. Now what happens in amelogenesis imperfecta? This organic matrix formation is abnormal. So because of this, the thickness of the enamel will be less. However, mineralization will be normal. So in amelogenesis imperfecta hypoplastic type, the organic matrix, that is production that you see, is abnormal. However, the mineralization or calcification process is normal. Because of this, it results in generalized pitting. And because of that pitting, you will see surface roughness. So this image you should never forget. This is a very classical image based question. What is the image based question you will see here? Okay, you will see that basically one second. Yes. Yeah. We were discussing that this is a classical image based question that we can expect pits that you see on the surface of the enamel with the surface roughness. Okay, and this is nothing but hypoplastic type of amelogenesis imperfecta, and this hypoplastic type is a one which is associated with the abnormal or reduced enamel organic matrix production. However, the mineralization or the calcification process is normal here. Moving on to the third question. Which of the following is not a major criteria for multiple myeloma? Which of the following is not a major criteria for multiple myeloma? To understand this question, let us divide the major and minor criteria. First, let us understand what is multiple myeloma. Multiple myeloma is nothing but malignancy of the plasma cells. And that too, this malignancy is occurring in the multiple positions. That is what is called as multiple myeloma. Now the multiple myeloma has got certain major criteria, certain minor criteria. Now what are the major criteria that you see? The major criteria is number one, plasmacytoma on tissue biopsy. That means if there is a multiple myeloma case, if you do a biopsy and if you see under microscope, you should be able to see plasmacytoma. Abnormal malignant plasma cells should be seen in the tissue. Second criteria, bone marrow plasma cells should be more than 30%. If you see the bone marrow, the plasma cell percentage should be more than 30%. Then third, on electrophoresis, you should be able to see M spike. In multiple myeloma, we have discussed that there will be one band actually called as M band or M spike. What is this? This stands for basically the IgG. So IgG increased production is seen in multiple myeloma. That results in the M or myeloma band on the electrophoresis. This is again a major criteria. Or Benz-Jones proteins are seen in the 24-hour urine sample. That is also a major criteria. So to remember the major criteria, one is on tissue biopsy, you should see plasmacytoma. Number two, on the bone marrow biopsy or bone marrow, you should be able to see more than 30% of the plasma cells. Third is presence of the M spike on the electrophoresis or Benz-Jones proteins presence of Benz-Jones proteins in the urine. These are the three major criteria. Now, what are the minor criteria? The minor criteria for multiple myeloma is the bone marrow plasma cells are 10 to 30%. That is a minor criteria sometimes. M spike is seen but less than above. That means if you see the M spike, it will be less, not so much. You will see lytic bone lesions. All of us know that if you see the skull, let me draw roughly a skull. Suppose this is a skull. We know that in multiple myeloma, the skull radiograph will show such punched out multiple radiolucencies. This is called as lytic bone lesions. That is again a minor criteria. Thirdly, the IgM level normally is less than 50 mg. IgA less than 100 micrograms, sorry, it's micrograms, and IgG less than. So you can leave this. You can leave this. If you forget also, doesn't matter. So if you see that these are the three minor criteria. So we have seen three major criteria and we have seen three minor criteria. Now coming to this question, which of the following is not a major criteria? Simple. Plasmacytoma and tissue biopsy, yes, it's a major criteria. Bone marrow plasma cells more than 30%, yes, it's a major criteria. Lytic bone lesions, is lytic bone lesions a major or a minor? Where have we seen? We have seen lytic bone lesions in minor criteria. So basically this is the correct answer, which is a minor criteria but not a major criteria for the multiple myeloma. So again, this criteria for multiple myeloma is again a very important MCQ that we are supposed to remember. Okay, next. Let us move to the next question here. This is just a histopathology to show how a plasma cells will look. See, I'll just roughly draw a diagram for you. So suppose this is a plasma cell. Okay, this is a plasma cell. Let me shade the cytoplasm lightly. Suppose this is the cytoplasm. How this will look is, this cell will look like this. This is a plasma cell. So eccentric nucleus will be there in a plasma cell. That means nucleus will not be in the center of the cell, just away from the cell. And remember, these are malignant. They are not normal plasma cells. These are malignant. That means they will show hyperchromatism. They will show pleomorphism. All those things they will show. That is what we are supposed to remember about the plasma cells in the multiple myeloma. Let us move to the next question. Which of the following is an important criteria to distinguish Mikulicz disease from Sjogren's syndrome? So we know that Mikulicz and Sjogren's are two important syndromes associated with the salivary gland. Basically, if you see, salivary and lacrimal gland enlargement. Can we differentiate based on this? No. In Mikulicz as well as in Sjogren's, both you will see this salivary and lacrimal gland enlargement. Schimmer's and Rose Bengal dye test positivity. No, because you can't differentiate. Sometimes in Mikulicz also you will see xerophthalmia, dryness of the eyes can be seen. Labial minor salivary gland biopsy, that is also not a specific criteria. I mean to say, it is seen in both. See, what this MCQ is saying, that out of the 4 options, 1 is unique for Mikulicz. 3 are common. IgG4 antibodies in the serum. This is the correct answer. Now, what is this question? This question says that in the Mikulicz and Sjogren's, 4 options are given. 3 options are seen in both. 1 option is seen only in Mikulicz. That is nothing but your IgG4 antibodies. Actually, Mikulicz disease is known as Mikulicz disease is an example of IgG4 related disease. IgG4 related disease. Mikulicz is an example of IgG4 related disease. There are a group of IgG4 related disease like Mikulicz is one example. We have Behcet syndrome. We have Behcet syndrome. We have Kuttner's tumor. All these are called as IgG4 related disease. So basically, Mikulicz is an example of IgG4 related disease. I don't want to go into details of the criteria for diagnosis of the Sjogren's syndrome here. Sjogren's syndrome, you have to remember that there are many criteria to diagnose Sjogren's syndrome. Okay, a rheumatoid factor will be raised. You will see anti-nuclear antibodies. ESR will be raised. Okay, all these are the things which are you'll see. But remember, for confirmatory diagnosis, of Sjogren's, of Sjogren's, you require labial gland biopsy. Labial gland biopsy. So we know that the lower lip, particularly the lower lip. One second, guys. Yeah. The labial gland biopsy, that is the lower lip, is usually is considered as a site from where the biopsy is done. And in this biopsy, you will check for the how many foci of lymphocytes are there per 4 mm square area. So you take a 4 mm square area, you check how many foci of lymphocytes. One foci is equal to 50 lymphocytes basically. So you take one foci and you check for how many, you take the 4 mm square area and you check how many foci are there. So that is called as a labial gland biopsy. So remember, again, this is an important MCQ. What is the most confirmatory diagnosis for the Sjogren's syndrome? Okay, so that is about the Sjogren's syndrome. Now let us move on to the next question here. The next question is, 70-year-old patient presented with a painful single large ulcer on the ventral surface of the tongue that did not heal for about 4 months. Upon clinical examination and history, the patient is a heavy smoker. Which of the following is not considered in the diagnosis? So here they say that ulcer is there, that too a large ulcer on the ventral surface of the tongue. Since 4 months, patient is a smoker. Which of the following is not considered as a diagnosis? Answer is basically, if you see, aphthous ulcer obviously is not considered, because aphthous ulcers won't stay for such long time. Look at the history, 4 months. Number 2, are aphthous ulcers very large? No, they are very small ulcers. Okay, they are very small ulcers. There will be multiple. Tuberculosis, yes, because we should know that tuberculous ulcers are also looking like malignant ulcers, and they also typically occur on tongue. They look like basically malignant ulcers. Large ulcers, undermined edges, all those things you will see in case of tuberculous ulcers. Squamous cell carcinoma, of course, squamous cell carcinoma, that is number the cancer where you will see such ulcer. Recurrent aphthous, that's the correct answer here. You don't see such, this history does not suit for aphthous ulcers. Erosive lichen planus, yes, sometimes erosive lichen planus can also present like this, where you can see the ulcer on the tongue. Okay, so that is what is the question. So now here, let us discuss some points here. Let us take some important points from this discussion. Tuberculosis. Classic oral lesion presents as solitary ulcer. Please remember this. Remember that tuberculosis will always present as solitary ulcer. There won't be multiple ulcers. There will be a single solitary ulcer. Undermined edge. That is what we have discussed. So they will have undermined edge. Typically on the tongue. So the ulcer is typically present on the tongue, followed by gingiva, floor of the mouth, palate, lips, and buccal mucosa. It is often painful. Please remember, this is very important. TB ulcer is painful ulcer. TB ulcer is extremely painful ulcer. Extremely painful ulcer. Okay, so that is what we are supposed to remember about the tuberculosis ulcers. Now, oral aphthous ulcers. Oral aphthous ulcers are also painful. They are also very painful, basically. Okay, and usually you see these usually they will heal. If you take the minor and herpetiforms, they will heal within 10 to 14 days. They'll not take so much time. However, major will take around 6 weeks. But in this history, if you see this in this question, what they have given? 4 months. Since 4 months, the patient is having ulcer. So that itself will tell us this is not a correct answer. Next, moving on to there is one there's one important correlation, negative correlation you have to remember. Smoking and recurrent aphthous have got negative correlation. What do you mean by that? In smokers, you will see less of aphthous ulcers. Why? Because aphthous ulcers typically occur on non-keratinized mucosa. Wherever there is non-keratinized mucosa, aphthous ulcers occur in that area. Okay, aphthous ulcers typically occur on non-keratinized mucosa. However, because of smoking, what happens? Because of smoking, the mucosa becomes keratinized. The mucosa becomes keratinized. Once the mucosa becomes keratinized, you will not see aphthous ulcers. So that is the negative correlation between the aphthous ulcers and the smoking. Aphthous ulcers and smoking. Moving on to the sixth question. The sixth question says that which of the following is not a diagnostic criteria for SLE? Which of the following is not a diagnostic criteria for SLE? We know that systemic lupus erythematosus has got anti-nuclear antibodies, anti-DNA antibodies. That's correct. It's a diagnostic criteria. Painful oral ulcers. Yes, in SLE you can see painful oral ulcers. I'm sorry, not painful oral ulcers. You'll see painless oral ulcers. Anti-phospholipid antibodies. Yes, you can see in case of SLE. Discoid rash. Sometimes you can see something called as discoid rash because that is nothing but your butterfly rash that you see in case of the SLE. So the correct answer is painful oral ulcers is a wrong. So usually in case of SLE, this is the point, the oral ulcers are painless. This is an important MCQ you are supposed to remember. In SLE, the oral ulcers are painless. Painless. Okay. Along with that, the patient will have other criteria like malar rash, we have discussed, discoid rash. They will have photosensitivity. Oral ulcers typically on the palate. Typically you will see it on the palate. Arthritis will be there. Serositis will be there. There will be proteinuria. Usually if you see 3 or plus more than that protein, you will see in the urine analysis. In the urine analysis in SLE patients. There will be basically neurological disorders, symptoms in case of the SLE. That is, seizures will be there, psychosis will be there. There will be hematological disorders like hemolytic anemias, leukopenia, lymphopenia, thrombocytopenia, all penia. WBC count is less. Okay, you see the hemolytic anemia, you will see that RBC count is less. You will see platelet count is less in case of the SLE. There will be anti-DNA antibodies, anti-SM antibodies, anti-phospholipid antibodies. You have to remember these three antibodies that you see in case of the SLE. Anti-DNA, anti-SM, anti-phospholipid. Okay, all these are the anti-nuclear antibodies basically that you see in case of SLE. So usually question in this, you have to remember this, that the main thing in SLE is painless oral ulcers and mainly presence of the anti-nuclear antibodies. Presence of anti-nuclear antibodies. Okay, let us move on to the seventh question here. The seventh question says that a patient presenting with features of multiple neurofibromas on the body with more than 10 cafe-au-lait macules and hamartoma of the eyes. The most probable diagnosis is, basically if you see here, this is nothing but von Recklinghausen's disease. What is von Recklinghausen's disease? This is nothing but neurofibromatosis. We know that neurofibromas are nothing but single neurofibroma will be there. Neurofibromatosis means multiple neurofibromas will be there in the body. So here on the body, in neurofibromatosis or multiple or von Recklinghausen's disease, you will see cafe-au-lait spots. That too, more than 10 cafe-au-lait spots will be seen. Okay. Along with that, the patient will have hamartoma of the eye. They will have certain nodules in the eyes called as Lisch nodules. Lisch nodules of iris is also seen in case of the von Recklinghausen's disease. Along with that, the patient will also have one more important feature, that is axillary freckling. In Sjogren's, in the neurofibromatosis, you will see axillary freckling, that is called as Crove's sign. This has been asked also previously in NEET paper. Crove's sign is nothing but axillary freckling. So axillary skin will be folded and it will be pigmented. That is called as Crove's sign. That is seen in case of neurofibromatosis. So neurofibromatosis, from this question, we have supposed to remember 3 points. One is, what is the take-home message from this MCQ? There will be cafe-au-lait spots more than 10 in number. Number 2, there will be Lisch nodules of the iris. Number 3, axillary freckling is seen in case of the von Recklinghausen's disease, and that feature of axillary freckling is known as Crove's sign. Okay. Next, let us move on to the next question here. Yeah, that is what is the question. The point here is that what are the diagnostic criteria? If you see, number 1, the cafe-au-lait spot should be 6 or more. So minimum 6. In neurofibromatosis, minimum 6 cafe-au-lait spots will be there. If 3 are there, 4 are there, you can't call it as neurofibromatosis. And look at that size also. They should be more than 5 millimeter. In pre-pubertal person. Post-pubertal person, they should be more than 15 millimeters in post-pubertal person. So after puberty, before puberty, you have to compare the size of the cafe-au-lait spots. More than 5 millimeter, more than 15 millimeter. Okay, so that is what you are supposed to remember. Then next, number 2, 2 or more neurofibromas. Axillary freckling should be seen. That is what we have seen as a Crove's sign. We have seen it as Crove's sign. 2 or more Lisch nodules, that is iris hematomas, optic glioma, a distinctive osseous lesion such as the sphenoid dysplasia, and very important, remember, neurofibromatosis is autosomal dominant. It is associated with the mutation of the gene called as NF1. NF1 gene is mutated in case of the neurofibromatosis. So there will be a first degree relative which is associated with the, basically, or if that is in that first degree relative also, there will be neurofibromatosis. There will also be neurofibromatosis. So you are supposed to remember that these criteria for the diagnosis of von Recklinghausen's disease, or the, you also call it as the neurofibromatosis. So this is a cafe-au-lait spots. I'll just show you this. You can see here, all these are the cafe-au-lait spots. So you are supposed to remember that the cafe-au-lait spots in von Recklinghausen's disease are smooth margin, whereas in case of the fibrous dysplasia, they are irregular margin. So remember that in case of von Recklinghausen's disease, they will have a smooth margins. And you can see the iris, these are all the Lisch nodules. All these things you can see brown, all these are nothing but the Lisch nodules of the iris. Okay, let me move on to the next 8th question here. The 8th question is, which of the following does not fit into Vickers-Gorlin criteria? Now, what is Vickers-Gorlin criteria? Vickers-Gorlin criteria is a criteria for ameloblastoma transformation. That is, if we have to see that if a cyst, one particular cyst is getting converted into ameloblastoma, it has to satisfy these Vickers-Gorlin criteria. It has to satisfy this Vickers-Gorlin criteria. Basically, if you see here, reciprocal induction. Is it, what do you mean by reciprocal induction? That means reciprocal. That means enamel is stimulating, ameloblasts are stimulating odontoblasts, odontoblasts are stimulating ameloblasts. That is reciprocal induction. You don't see, that is not a criteria for Vickers-Gorlin criteria. Reversal of polarity of nucleus. Yes, this is seen. Subnuclear vacuolization. Yes, this is seen. Nuclear hyperchromatism. Yes, this is seen. Increased nuclear cytoplasmic ratio. No, that is not seen. Nuclear palisading. Yes, you'll see. So if you see, these are the 4 Vickers-Gorlin criteria. So 2, 3, 4 and 6. So this is the correct answer, if you see. Okay, as we have discussed, Vickers-Gorlin criteria is, suppose these are the ameloblasts, tall columnar ameloblasts. The nucleus will be palisading hyperchromatic nuclei, that too showing reversal of polarity. This is a basement membrane, for example. So the nucleus, if you can see, the blue one which I have shown is a nucleus. It is situated away from the basement membrane. That is called as a reversal of polarity. And the nucleus are at the same level. That is called as palisading. Nucleus are dark. That is called as hyperchromatism. And just below the nucleus, here you will see a vacuole. What is a vacuole? An empty space. An empty space you will see. So this is called as Vickers-Gorlin criteria for ameloblastomatous transformation. So this is what is the typical, you can see. So suppose this is a basement membrane. I just draw the basement membrane here. So look at the nucleus. Where are the nucleus located? You can see the nucleus are located here, away from the basement membrane. That is called as a reversal of polarity. Reversal of polarity. Okay, let us move on to the 9th question here. An individual of age 45 years is found missing from the past 1 month. Later on, an unidentified, decomposed and burnt body was retrieved by the police. Which of the following methods can be applicable for age estimation of unidentified body using teeth as a source? So this is actually a forensic odontology question. According to this question, the correct answer is actually the Johansson's method. Okay, Johansson's method. What is Johansson's method is? Johansson's method is actually it is a modification of Gustafson's method. We know that there is Gustafson's method of age estimation. Johansson is just a modification of that. And this is a method that you can use it in case of burnt bodies, decomposed bodies. The teeth can be used as a source. So I will directly go to the discussion of that. In Johansson's method, which is a modification of Gustafson's age estimation method, you use parameters like attrition, dentine deposition, loss of periodontal attachment, cemental apposition at the root apex, root resorption at the apex, and loss of dentine translucency. Loss of dentine. So these are the 6 variables that are used in case of Gustafson's method, and Johansson has widely recommended these important criteria for age estimation. So Johansson's is just a modification. Remember, Johansson's is just a modification of Gustafson's age estimation method. Now, you have to, among this, so see, all look at this. What are these 6 criteria? All are age related. Attrition. With the age, the tooth will get attrited. Secondary dentine deposition. We know that basically dentine is of 3 types: primary dentine, secondary dentine, tertiary dentine. Dentine that is formed before root completion is known as primary dentine. Dentine that is formed after root completion is known as secondary dentine. So secondary dentine is continuously deposited throughout the age. Okay. Loss of periodontal attachment, that is but common, very common, obvious that due to age, periodontal attachment is lost. Cementum is deposited at the root apex. Yes. Root resorption is seen, and loss of dentine translucency. Remember, this loss of dentine translucency is considered to be the most reliable indicator or criteria for the Gustafson's method. Sometimes you can expect this question also. Actually, this is a all India AIPG question. Previously we had AIPG, right? So this is the AIPG question. If you can see the AIPG question MCQ bank, you will get this question. Which of the following is a most reliable indicator or criteria for age estimation, Gustafson's age estimation method? Loss of dentine translucency. Normally dentine will be translucent. With the age, dentine translucency is lost. Why? Because obviously dentinal tubules will get calcified. Dentinal tubules will get calcified. So because of the calcification of the dentinal tubules, dentine translucency is lost. Dentine translucency is lost. Now, if we can see what are the other options here, the other options that we can see here is Kaur and Massler, Demirijan's method, and Chiaparelli's method. So basically, the Chiaparelli's method is basically on a based on neonatal line. So please remember this. The Chiaparelli's method of age estimation is based on neonatal line. That's it. You have to remember. Kaur and Massler and Demirijan are basically in children. Usually do it in children, and that too basically based upon their tooth development and calcification. So based on the calcification, how much tooth is developed, how much root is developed. Okay, there will be a chart. So it's basically a chart method. Kaur and Massler and Demirijan are chart method. So you will have a chart. With that chart, you will compare and based on that you will come to the age estimation. That is called as Scour and Massler and Demirjan's method. So these are the age estimation methods that you are supposed to remember. Among that, the most important one is the Gustafson's method, that too the Johansson's modification. Let us discuss the last MCQ for today. The below picture represents which type of endogenous discoloration? Typically, if you see this, basically this is a reddish brown discoloration you can see here, and this is typically seen in case of porphyria. Basically, typically in case of porphyria. So we know that all these examples are basically the discoloration. These are all the conditions where there will be tooth discoloration. Tetracycline related discoloration. We know that tetracycline is an antibiotic which should be avoided till 8 years of age. During pregnancy it should be avoided, otherwise it will lead to the yellowish discoloration, grayish yellow discoloration of the tooth. Porphyria is basically a genetic disorder in which porphyrins are deposited in the teeth. So this is a brownish discoloration of the tooth. And if you use Wood's lamp, what is Wood's lamp? This is a source of UV light. This is a source of UV light. So this Wood's lamp, if you see, the tooth will show basically the reddish brown fluorescence. Reddish brown fluorescence. So basically in porphyria you will see reddish brown discoloration of the teeth, and if you apply Wood's lamp UV light on that, you will see the reddish brown discoloration. Hyperbilirubinemia related discoloration. In hyperbilirubinemia there will be usually bluish discoloration of the tooth. And dentinogenesis imperfecta. Dentinogenesis imperfecta will not be so dark. That will also be brown but yellowish brown. Okay, and you will see bands basically in dentinogenesis imperfecta. So totally a brown, dark brown, chocolate brown discoloration is characteristic of porphyria related discoloration. Okay, so that is what I just wanted to discuss here. You can see this porphyria related discoloration. Yes, marked reddish brown discoloration. So what is the meaning of marked? Marked means in porphyria related discoloration, the reddish brown will be marked. Means that will be very dark. So this is a tetracycline staining. You can see typically yellowish brown, that too light yellow gray color discoloration, and that too again you have to use UV light in here. This is the hyperbilirubinemia image. You can see I've told you that bluish discoloration will be there. Typically gray to blue discoloration you will see in case of the this condition, mainly because basically we know that bilirubin is broken down into biliverdin. Okay, the biliverdin results in basically the blue discoloration. Okay, blue discoloration. So that is about the various MCQs we have discussed today, and the answers, correct answers, and the explanation. So any doubts in this session, you can definitely comment it. Okay, I'll definitely see the comment and reply to your comment. Otherwise, I hope this session would have helped you, and we'll have many more such sessions in the future. Okay, thank you so much for your patient listening.